I'm Mike Naylor, Principal Consultant Health at Oxford Policy Management, and I'm also the Director of HEART. So the team that conducted this work on voice and accountability in Bangladesh health sector was myself, Rumana Hook, who is from the University of Dhaka and who we sourced through our partner in Nuffield, Leeds, Richard Nash, who is a DFID governance advisor, somewhere on the Horn of Africa, or was, I think, at that time, and he joined the team as part of his 10% arrangement, and very useful he was, and we had very good support from the Bangladesh office, technically from Dr. Shalina Ahmed, and we also had support from the procurement function, which I would have said was robust for in relation to this particular assignment, but eventually very helpful to it. The objectives of the assignment, and these were set by DFID, but on behalf of government and other partners, was to take a sort of strategic look at voice and accountability and make some recommendations ahead of the joint annual review that takes place in Bangladesh. I would say about this commission from DFID that it was pragmatic, it was limited in its aims, which I think is helpful. Basically to have a look at what was happening and what could be learned and what could be shared from what's happening ahead of that strategic event in Bangladesh. Sometimes we get terms of reference which are rather too large, and can lead to disappointment. This I think was well framed by the DFID office. And we looked at voice and accountability from three perspectives, and Richard, the governance advisor, was very helpful in framing this and in terms of giving us some sense of the DFID's political economy, analytical framework. So we looked at this in relation to the political economy of Bangladesh, the general enabling environment within Bangladesh, whether in terms of citizens, in terms of the media, in terms of the legal framework, and we looked at it in terms of health systems framework and directions. Pretty classic approach, key informant interviews, a lot of meetings in Dhaka, and a number of visits, which, since it was in the middle of Ramadan, was quite a challenge in terms of making those visits, but very effective they were. And then an international literature search and summary, which is available as well as this report on voice and accountability. And that was conducted by IDS. So IDS, our partner in HEART on knowledge services. So we looked at a number of case studies of voice and accountability. I needn't explain what all these letters mean. Some will be familiar to you, like plan, and care, but this looks like a lot of NGO activities in voice and accountability. In fact, all of these activities are taking place within a quite well-defined government framework. So although it's NGO activity, it's not highly independent NGO activity. We had interesting discussion with the Ministry of Health around this topic, and if we look at that section on voice, I think this was quite interesting that they said that previous engagement of citizens, I think previously they're talking about 2 decades ago, and perhaps even more, was essentially around getting compliance from citizens rather than participation of them. And this was interesting insight from the government. But I suppose you're all aware of the sort of, in a sense, the Bangladesh phenomenon of relatively low expenditure and very good results. And I think compliance and the way in which all of government mobilizes itself around health campaigns is one characteristic of that. So This was an interesting perspective. They now said that they want to move on from that. They still want compliance, but they also want an approach about respect for clients and a more proactive approach to service providers. Now, looking at what is happening in terms of voice and accountability and the focus of most of that work by the NGOs, there really is a most significant initiative, yeah? That started over a decade ago by the present government, and still the present government, was abandoned by the next government, as happens in Bangladesh, and then reinstated by the government. And that is over 40,000 citizen groups meeting around health issues. Now, I would not claim, because I've probably visited about 10 of these, yeah? So I can't say they were all working like those 10, but the scale of this is really quite stunning. Yeah, of 40,000 groups of citizens meeting reasonably regularly to discuss health issues, to make suggestions, to criticise local providers, to advocate for better services. And from what I saw, undertaking the key role of such citizen group or health centre group, and that is in governance, in support, including financial support to the facility, and in advocacy to higher levels of government. So this is now I'll come on to the issue, the perspective of health partners, but have that in mind. An initiative involving 40,000 citizen groups in Bangladesh. The other thing that I think I found particularly interesting was some of the innovatory approach of the Ministry of Health, and this is very much around the fact that information technology is becoming much cheaper and networking is becoming much easier around information technology, and that opens up a lot of new possibilities in voice and accountability. So, for example, doctors in peripheral areas in Bangladesh were being asked to present themselves on Skype in the morning, with a backdrop which was clearly the hospital. And, well, we wouldn't have been doing that, 5 years ago. And every community health worker in Bangladesh now has a tablet. And that means that within a week, or probably within 24 hours, depending on how accurately and timely the data is put in, it means that at every level the same information is available. Not from 3 months ago or 6 months ago, but what happened last week and what happened a month ago. So this is throwing up new possibilities, not just for health information systems, but also new possibilities around voice and accountability and some of the democracy around provision of health services. So you hear a lot of bad things about the government in Bangladesh, but at the level of technical staff within the ministry, very interesting things happening, very cost-effective things happening in Bangladesh. The development partners, and I would say that what they said to me in a sort of a group that they have, they're looking at voice and accountability with the government, was very much echoed also by the meetings we had with the media in Bangladesh. And this, for me, raises some questions of elites talking to elites around questions of accountability, because it was the same story: disillusionment and disappointment with the government. One of the partner representatives saying he was very inclined towards the notion of naming and shaming as the approach that should be adopted. And I did say to him that if someone from Bangladesh came to his country and with a program of naming and shaming, it may not be best received within, well, I won't tell you which country that was. There was disappointment that the partners' agenda of an annual stakeholder analysis was no longer being followed. So there was huge enthusiasm for this from the partners and very little from the government about this annual stakeholder analysis. And so this was tending to be equated to the government no longer being interested in voice, no longer interested in issues of accountability with citizens. There was a general lack, this did not apply to DFID, by the way. A notable exception in this group. There was a general lack of appreciation of what government was doing. There was not an appreciation of the scale of this program of citizen groups meeting, and nor really of some of the technological innovations that were taking place. Voice and accountability tended to be seen as a good thing in itself. This was something that Bangladesh needed, and partners would fund ways of making sure that they got it, rather than being linked into developments within the health system. And the particular group was not well engaged with the key government players, or vice versa. I had 3 meetings with this group, so this wasn't one meeting, and I came away with exactly the same sense, that there was not really an understanding or effective engagement around voice and accountability from the partners, in spite of the fact that a swap has been well established in Bangladesh in health for some time. And then I'm not going to go through these. These slides are available if anyone wants to look at them afterwards. In terms of the initiatives we looked at, some of them, like women-friendly hospitals, I think was largely partner agenda, but adopted, and with some enthusiasm in some of the hospitals. The third to last bullet around initiatives aimed at increasing information for individuals, citizens and organisations. This tended to take the form of rather weighty reports and publications. I mean, not something you would find on the desk of the Upazila chairman, but you would find in the sort of elite community around health in Dhaka. There were some initiatives around demand side, an inevitable question in terms of voice and accountability, but still quite limited, to quite small voucher schemes, and some interest in community health insurance, which has not yet developed into anything major. Some of the lessons, a key lesson was that these community groups, or facility health committees, sometimes named, the conclusion we came to from the literature search and in Bangladesh is they need about 3 years of third-party support on average, to be able to sustain themselves. This is not a quick fix, something that can be done with a bit of training and let them get on with it. The third bullet, local government was really important, and particularly the role of women councillors in forming a link between these groups and then levels of government. And the last bullet around cross-party consensus. This was a lesson that one government shouldn't do something and it's completely overturned by the next. Frankly, it's a bit of a joke in Bangladesh. As you know, the election took place, the opposition didn't even take part in the election, and so there is this great polarization within Bangladesh, which is unfortunate. In terms of other lessons, local governments have what they call discretionary funds, and so these are quite close to the action. This is not money in Dhaka, it's money close at the union level and the Upazila level. And that money was being used quite cleverly by chairmen of these local governments, receiving ideas from these community groups passed up through the system, often by the councillors. Third bullet, when you go to these groups, they are elite captured, you might say. Yeah? It's the person who used to be the teacher or the retired civil servant and so on who are the most active members of these groups. In Bangladesh, that is probably inevitable, but there needs to be thinking about how you apply some counterweight to that. NGOs are very important in doing that. The danger with NGOs is they like to impress. And so we saw a few examples of NGOs themselves funding service delivery initiatives, which were then not sustainable. So they would fund an initiative, say a laboratory at the lowest level of health facility that clearly was not going to be sustainable in terms of government funds or in terms of out-of-pocket expenditure. So that is not desirable. So the conclusions from our work, that there is legitimized space in Bangladesh for activity around voice and accountability, that governments are aware of their own weakness, historically in this respect. Governments very concerned about a high level of individual out-of-pocket expenditure and there not being accountability. On the other hand, that expenditure actually does give poor people some power when they have the money in their pocket. And particularly, I think you'll be aware of the garment industry and the garment factories employing millions of young, usually rural women in Bangladesh who now have money and can pay for services. So it's an interesting dilemma that in terms of the way we would normally look at out-of-pocket expenditure. And the words voice and accountability, and this is not just in Bangladesh, I found the same in Zimbabwe recently, themselves can be a barrier to engaging government. Accountability is a term that there is nervousness about when it comes externally. Some further conclusions. This was an election period, running up to an election period. So there were perils of that. There are also opportunities in an election period to create a platform around health issues. But in my view, this was not strong in Bangladesh because of the political polarization. Unlike, for example, in Nigeria, where at election time, DFID has been very successful with other partners in creating platforms around health during the election. Third bullet down there, decentralization and power of discretionary funds. This we found very important in the Bangladesh context. Going to Zimbabwe on a similar, looking at similar things recently, I came to the opposite conclusion, that putting too much money out on a discretionary basis was fragmenting the system rather than making it more effective. So this is not an automatic lesson from everywhere. In a health system performing well with low resourcing, a case needs to be made positively for enhanced citizen participation. The cost, this is per 10,000 people for 5 years of this sort of activity, supporting community groups, is about $5,000. So that's about, in Bangladesh, so that's about 10 cents US per citizen per annum. Now that doesn't sound very much, but you add it all together over 5 years, that's $65 million. So you could spend $65 million on other health initiatives that might have a higher return than these committees. So I think the economics of this do have to be taken seriously. But from what we saw, that $5,000 would probably be repaid in in-kind contributions over that same period. So there's likely to be a positive return. The question is that positive return greater than if you spent that money on other activities? We didn't get into that depth, but I think it's an interesting question. And there's not been a lot of costing of these initiatives done. So a small-scale project I was involved in Kenya, we were looking at 50 cents per person per annum. That was about now nearly 10 years ago. So probably quite a variation, and this at the relatively low end of the spectrum. So our conclusions, and these are in greater detail in the report, that government should take to scale these citizen committees based around health centres and community support groups, that they should look, with help from partners, at using these technological innovations combined with this well-established network of citizen committees to see what added value could be achieved from that. So, I mean, you could do a stakeholder analysis of 40,000 locations, with a quick survey, when every community worker has a tablet. So beginning to think about those sorts of uses. Adding to discretionary funds would be very helpful at the level of the union and UPAZILA. In terms of hospitals, which I've not talked about very much, there is quite a lot of citizen activity. It's much less effective. And the main reason it's less effective is that the formal structures themselves, like hospital management committees, are not very strong. These think tank organisations that produce these weighty reports every year, our recommendation was that they shift emphasis. They engage in the same quality of research, but they make that available in a form that can be digested and used at these lower levels of the system, particularly by local government players. And finally, the various NGOs involved in identification and dissemination of tools and methodologies should work closer together. There are a lot of very good tools, a lot of very good methodologies, but not a great deal of talking between the different organisations. And for those interested, the report goes into those recommendations in more detail.